Okay, it is 1 o'clock, so I think we'll get started. I know some people are coming into the room right now, but I'd like to get started on time. So hello, everyone, and welcome to the Healing Community Study Learning Collaborative. My name is Lisa Romley, and I'm the Education Program Coordinator for the HEAL Study. We're here today to learn and discuss evidence-based ideas that can be implemented using the opioid abatement funds. I just need to review a few housekeeping items before we get started. Just a reminder that this session is being recorded. And if your screen name is not your full name, either you have a partial name or you're using your phone number, if you could please update that now and change it to your full name. This helps when we compare the participant's name in the session to the registration list. We are offering CE credits. One CE credit has been approved for physicians, pharmacists, nurses, social workers, and licensed alcohol and drug counselors. And I'll give you instructions at the end of the session how to obtain that CE credit. We also offer certificate of attendance. So if you don't fall into one of those professional groups and you want a certificate of attendance, you can certainly do that too. And then just for this session, we are offering DLG credits, and this is for fiscal court members, jailers, and sheriffs. And for those wanting DLG credit, you do need to keep your video screen on for this entire session. And then after the session, I will be sending the attendance sheet to Wendy Thompson, and then she'll process the claims for the DLG credit. We do ask that you stay on mute throughout the session just to help reduce those echoes and extraneous noises. And if you have questions, and we do welcome your questions, because today we have 9 presenters, we are going to hold the questions until the very end and open it up during our Q&A time. But feel free to type your questions in anytime and put them in the chat box, and then we'll read them during the Q&A session. Just a report that all presenters today stated that they do not have any relevant financial relationships to disclose. And the practice gap and the educational needs that will be addressed, Kentucky's expected to see about approximately $842 million in opioid settlements. So education of these evidence-based strategies are needed to help inform communities when making decisions about these funds. And the learning objectives for today's session, we're going to provide an overview of the HEAL study and their efforts and goals, and then also a discussion of the ORCA strategies that have been effectively implemented throughout the study. We'll have a discussion about the cost of these strategies and the process of pursuing these funds. And then hopefully at the end of today's session, you'll have a good understanding of what these evidence-based strategies are that have been implemented in the study and have been effective with individuals with opioid use disorder. So for today's learning collaborative, we have a phenomenal group of speakers from our HEAL team who have done great work with the study. And I'm going to briefly introduce each of them right prior to their presentation. So first up, we have Jennifer Miles, who is the Executive Director of the HEAL study. I will now turn it over to Jennifer.
Thank you, Lisa, for that introduction. So we're going to start with, what does HEAL stand for? HEAL stands for Helping End Addiction Long Term. This is a large umbrella of research that was funded by the National Institutes of Health, and the Healing Community Study was funded under this large initiative. The Healing Community Study was designed to establish best practices for integrating prevention and treatment strategies that can be replicated in communities nationwide. It is an implementation study taking place in 4 states and in 67 communities, urban and rural, that test the impact of an integrated set of evidence-based practices across healthcare, behavioral health, justice, and other community-based settings, with the overall goal of reducing opioid-related overdose deaths. Next slide. The 3 main components of the intervention were community engagement, a communications campaign that was designed to reduce stigma surrounding naloxone and opioid use disorder, and the creation of the opioid overdose reduction continuum of care approach. We will refer to this menu as ORCA throughout the presentation today. To accomplish the community engagement component, the Kentucky team began with the Agency for Substance Abuse Policy Boards, and they then expanded that participation and membership to local community members and partners who work with individuals with opioid use disorder. This formed coalitions to advise and assist the team in identifying gaps in the local communities, advising on the evidence-based practices that would be implemented in those communities, and the communications campaign. And many of those coalitions will remain active in the 16 counties when the Healing Community Study is complete. Next slide. We're going to spend most of our time today talking about the opioid overdose reduction continuum of care approach. Over 300 faculty members reviewed research data and outcomes from thousands of research studies to develop this menu of evidence-based practices that were approved and adopted into this menu. There are three main sections of the menu. There's the opioid overdose prevention, education, and naloxone distribution in high-risk populations, which we refer to as OE&D. There's effective delivery of medications for opioid use disorder by linking to and retaining individuals in treatment. And the third part of the menu is safer prescribing, dispensing, and disposal of medications for opioid use disorder. Next slide. ORCA is relevant for behavioral health, criminal justice, and healthcare settings. This is a list of locations where the Kentucky Healing Community Study team implemented in those 16 communities. These locations were chosen by the community coalitions. In addition to the locations shown here, some specific Kentucky partners were the Office of Drug Control Policy, the Department of Corrections, the Administrative Office of the Courts, the Cabinet for Health and Family Services, the Department for Public Health, the Director of the Division of Local Facilities, and hospitals. Next slide. So how does the ORCA help? Not only does it provide the evidence-based practices needed for opioid abatement funds, during its development, the teams focused on specific populations that are heightened risk for opioid overdose death and ensured that the practices cover the spectrum of individuals from those who currently do not use drugs to those that are in sustained recovery and remission from opioid use disorder. The ORCA menu is designed to work with communities of all sizes and diverse populations with the intent to identify, reach, and work toward equitable outcomes for those who have been systematically underserved and disproportionately affected by fatal overdose. Next slide. To close, I'm providing links to the practice guides that were developed from the Healing Community Study team. These are on publicly available websites, and they provide further guidance and information about the ORCA menu, as well as engaging the community coalitions to focus on reducing opioid overdose deaths in your communities. Thank you, Lisa.
Thank you, Jennifer. Next presenting, we have Dr. Margaret McGladrey. She is a research assistant professor with the Center for Innovation in Population Health and serves as a criminal legal system faculty co-lead for the HEAL study.
Thanks so much, Lisa. Let's go on to the next slide. So as Jennifer had reviewed some of the basics around the Healing Community Studies, I'm going to go ahead and answer some frequently asked questions about the Opioid Abatement Fund. So first, what are the abatement funds? As a party to a series of nationwide settlements with opioid manufacturers and distributors totaling more than $54 billion, Kentucky will receive, as Lisa said earlier, approximately $842 million in opioid settlement funds to be paid out in installments through 2038. Kentucky local governments have already received allocations and schedules for future payment installments from the 2022 settlement with the three major pharmaceutical distributors in Johnson & Johnson, totaling approximately $239 million. An additional $326 million, $181 million for local governments was announced in December 2022. Next question, how are the funds managed? Oh, I'm sorry, go back to the last slide. How are the funds managed and how is Kentucky spending the funds? The Kentucky Opioid Abatement Advisory Commission, or KYOACAC, provides oversight and management of the settlement, ensuring that all funds are distributed in compliance with Kentucky Revised Statutes 15.291 through 15.293, which we'll be talking about in more detail in a moment. While half of the funds are distributed via a grant program managed by the commission at the state level, the other half is allocated to local governments based on the national settlement formula, considering population, opioid deaths in the area, and other factors related to the local impact of the opioid epidemic. The next question, how can my jurisdiction apply? So the state's portion of the settlement is being distributed via this grant program managed by the commission. Any entity or governmental agency may apply for funds through the grant portal, including local government units that receive funding at the local level. To answer the question of how much may my local jurisdiction receive, you can see the link at the bottom of this list here, the CAICO link here that Lisa is pointing to. How much will our local jurisdiction receive? When you get the slide deck, you'll be able to click on the link and see a table that goes through the original settlement, Johnson & Johnson and 3 major pharmaceutical distributors, what the county-specific allocations will look like. Participating counties and their constituent participating cities may distribute the funds amongst themselves in any manner they see fit. If counties and constituent cities and towns cannot agree on how to allocate funds, then the money is distributed by a trustee jointly appointed by the Kentucky Association of Counties and the Kentucky League of Cities. To answer some of the questions that we received before this session, the recipient of local abatement funds is generally the fiscal court or its designated trustee, with the county attorney being responsible for working with Rubrus, which is the settlement implementation administrator, and submitting the required settlement participation forms. To our knowledge, only Louisville and Lexington have formal local commissions to decide how funding will be used. To influence how monies are being used locally and ensure community really benefits from and agencies are able to be considered for local abatement funds, we recommend talking with fiscal court members and attending fiscal court meetings to learn more about how the local abatement funds will be used and ask questions about how decisions will be made. The Kentucky Association of Counties, or KACO, is a great resource for understanding how county officials are being advised to receive and manage local funds. KACO is also working with Vital Strategies to place a full-time staff member at KACO to provide strategic guidance, planning, and implementation support related to the opioid settlement funds for Kentucky counties. Another question was how to leverage opioid abatement funds with other funds and/or grants. If your agency already has a grant for which the funding parameters align with abatement funds' allowable uses, then fiscal courts may be interested in supporting complementary programming to enhance impact. If your agency receives local or state funding from the Abatement Commission, then you may consider including a letter of support from the fiscal court and/or a letter of award from the state commission describing this funding as in-kind support for other related grant applications. For example, CORE could be braided with opioid abatement funding as long as the abatement funds were used as a payer of last resort ahead of CORE, which is federally required to be the payer of last resort. And most grants also specify that you can supplement but not supplant funding. On to the next slide. So a little bit more about I think this one may be out of order, Lisa, if we could go to the next one, the state. Yes. So in terms of the state level commission, you can go to the link on this slide here to learn about what projects have already been funded. You select your county from the drop-down list and you can see what organizations were funded, the amount of the grant, and the focus on prevention or treatment and recovery of that grant. Competition is fierce at the state level, and proposals require the same level of grant writing capacity as typical state, federal, and foundation mechanisms. $25 million was available in the most recent funding cycle, but over $150 million in requests were made. Applications for the state commission funding will reopen on January 1st, 2024, and we anticipate announcements as soon as this week about the second round of funding decisions. The full list of requirements, access to the application portal, and FAQs can be found on the commission website. If you could go back to the last one on allowable uses, Lisa. So one of our questions received before today was how funds are permitted to be used by the local government. These uses are specified in KRS 15291 Section 5, which Lisa will be placing in the chat. And these requirements around allowable uses are the same for both state and local funds. You'll be looking at page 2 of this Kentucky Revised Statute, Section 5, to see the whole list. And you can see a screenshot of the top of that section of the KRS here on the slide. On to the next one, Lisa, on local documentation requirements. Each local government shall submit certification to the commission that the funds were used and consistent with the criteria that you're going to see in the file here, as well as a list of fund recipients, amounts, and a description of the use of funds and any other information the commission requests through the promulgation of an administrative regulation. The form that is included in this link that you see here from CAECO requires the recipient to affirm under penalty of perjury that the use of the funds is in compliance with KRS 15291 and 15293. In signing the form, the recipient also agrees to maintain for 5 years all necessary records, including where relevant itemized receipts, financial statements, and accounting data to authenticate the recipient's use of opioid abatement funds. The commission reserves the right to inspect such records, and the form must be completed by an authorized individual and notarized. Counties receiving opioid settlement funds must submit quarterly certifications to the commission due on the following dates of the year: March 31st, June 30th, September 30th, so coming up here, in December 31st. Another note from the 15293 statute is that money in the fund shall not be expended at the close of a fiscal year. It will not lapse, but be carried forward. So this funding is not does not expire at the end of the period in which it was awarded. 2 final slides for me. So the next one is resources for addressing stigma. Before the presentation, we received a question about how to overcome stigma of emergency management and fiscal court members. And this slide includes links to 4 relevant trainings from the NIH-funded Justice Community Opioid Innovation Network, as well as the Kentucky Communication Campaign Toolbox, and a website for the Unshamed Kentucky campaign with which HCS partnered. So those first 2 presentations in particular, the stigma course for county executives and stigma course for state and local leaders, may be relevant in addressing the question. And then a crosswalk in this next slide, Lisa, to looking at that ORCA evidence-based practices menu that Jennifer overviewed and lining it up with the Kentucky revised statutes. What you'll see here is that all of the evidence-based practices from the HCS ORCA that you're going to be hearing more about from my colleagues today directly align with allowable abatement fund uses. And this graphic crosswalks the ARCA menu to the relevant items in 15291 Part 5 that you have in the chat here. And to answer one final question we received before the presentation, item number 4 of the statute allows funding to be provided for projects that support transportation to treatment or recovery programs or services. Medicaid is working with CMS to begin to cover transportation to methadone appointments, but we don't know when this will go into effect. But it's clear that an allowable use for these funds is supporting transportation to recovery services. Back to you, Lisa.
Thank you, Margaret. And for our next presentation, we have 2 presenters who will provide an overview of the Menu 1 strategies. Dr. Doug Euler is a member of the prevention team, specifically aiding in overdose education and naloxone distribution. Also presenting with him is Dr. Hannah Knutson, who serves as a co-investigator on the HEAL study and a faculty lead for the implementation facilitator team. I will now turn it over to them.
All right. Thanks, Lisa. So I'll start a little bit by kind of giving some of the evidence behind why we're looking at overdose education and naloxone distribution as a strategy here. And then I'll pass it over to Hannah to talk about how we implemented this. So going back, this is the Surgeon General from the last administration. So this is stuff that's not entirely new here, right? But a public health advisory suggesting that everyone know how to use naloxone and keep it within reach that can save a life. So public health advisories being the same types of things that say, everyone should know basic life support, everyone should know CPR, the same type of thing as a strategy to combat overdose deaths, because so many individuals are dying from this. Everyone should carry naloxone. Can we move to the next slide, please? So a little bit about how this works, and this will come to play here in a couple of slides, and we dispel some of the myths. So when we talk about opioid pharmacology and how naloxone works as an antidote to opioids. So opioids work on opioid receptors. These are throughout your body, throughout your central nervous system in your brain, other parts of your body, different types of opioid receptors. And you have your own endogenous opioids that your body makes in response to pain and other potentially stressful stimuli. So when we talk about this, we'll have things like receptor activity, and there's different types, right? Mu, delta, and so forth. And so we have receptor activity and receptor affinity. So receptor activity is like agonists or antagonists. So you can bind to this receptor if you're an agonist and kind of activate that downstream pathway, whatever happens. So mu opioid receptor agonist would be what you think of when you think of most opioids, or fentanyl, methadone, oxycodone, heroin, and so forth. Antagonists are things that bind to that receptor and don't produce any effect. So they don't bind and produce the opposite effect. They bind and produce really no effect at all. So that would be stuff like naloxone and naltrexone. Then we have receptor affinity, which would be essentially high or low, how tightly this drug binds to that receptor. So high opioid or high mu receptor affinity drugs would be things like fentanyl, buprenorphine, naloxone. And lower would be codeine. So you can see in the picture here kind of different receptors in different locations and what those do. The one that's particularly important when we talk about overdose is there in the brainstem that regulates breathing. Next slide, please. So when we talk about naloxone, naloxone has a higher receptor affinity than many opioids, but not all opioids, right? So fentanyl and analogs, maybe that's some of why they may require more naloxone potentially than other opioids. What it does here essentially knocks the agonist off of that receptor, but it doesn't produce an effect. So it's not like it produces the opposite effect, right? It doesn't produce any effect. So that's why it's an antagonist. What happens here is effectively you reverse the effect of that opioid. So breathing is restored and potentially you can get some precipitated withdrawal. Lasts between 30 to 90 minutes, so doses may need to be repeated, especially for extended release, long-acting products, and so forth. Next slide, please. So looking on an individual level, the evidence supporting overdose education and naloxone distribution, so this kind of combined strategy here, what we know is that if you're overdosing and there's a bystander who administers naloxone, you're about 8 times more likely to survive. So this is 10-year-old data almost now. So we've known this for a while. You're significantly more likely to survive if there's a bystander that can administer naloxone versus if there's not. Next slide, please. And on a community level, what we see is, so this is from Massachusetts, again, nearly 10 years ago now. And the data that was used for this is over 10 years old at this point. But looking at community level, the more naloxone that's available in communities, so that essentially the degree of enrollment within target populations here, the more naloxone that's available in communities, the lower the opioid overdose death rate adjusted per population in those communities. Next slide. And this has led to recommendations from several different groups, which are listed here: HHS, the World Health Organization, several medical, pharmacy, and other associations related to that, as well as SAMHSA, the CDC, and the FDA, all supporting the availability of naloxone and overdose education as an evidence-based practice. Next slide. So you mentioned, or you may notice I mentioned overdose education and naloxone distribution. So this is a little bit older. So before we had the over-the-counter labeled naloxone a little differently, but up to a third of people may actually administer naloxone improperly without education. So either they, so we're here mostly talking about the intranasal device. So either they don't place the device in the nostril, maybe they don't actually push the plunger down, anything like that. So these are the most common things. And maybe some of this is mitigated by, again, new labeling in the over-the-counter product that recently came out. But what we put together was more than just how do you give somebody naloxone, right? So our healing community study, educational materials, looked also at what does an overdose look like? What are all the steps in responding to an overdose? Call 911 and so forth. And then how do you reduce somebody's risk for overdosing in the first place? Next slide. Next, I'll spend a minute here dispelling some of the myths associated with OEND. So we know, in all the references here at the bottom of the slide, if you're interested in kind of digging into this some more. But overdose education and naloxone distribution, it does not encourage drug use. It does not encourage use of more drug. And some evidence suggests that it may actually decrease drug use and increase treatment and treatment retention potentially. So naloxone, we know, does not cause aggression. Remember, it's an antagonist. It goes onto that receptor and essentially nothing happens. It doesn't produce the opposite effects, right? It binds there and doesn't produce the agonist type effects. It's been around for 50 plus years as a reversal for sedation and things in the PACU and in perioperative spaces as well. Intranasal drug delivery does not require the patient to be breathing. So that's a question that comes up a good amount. So the drug's actually absorbed right there in the nose, so they don't have to breathe it down into the lungs. As we mentioned before, multiple doses may be required for highly potent opioids like fentanyl or potentially carfentanil and others. And then there are multiple Kentucky laws that are cited here that provide specific protections for individuals who prescribe or administer, distribute naloxone. So Good Samaritan laws, as well as civil and criminal liability protections for individuals that are involved in naloxone distribution programs. Next slide, please. The last thing that I'll talk about here is, again, trying to target this strategy. So looking at known risk factors for opioid overdose. So some of this can be beneficial, just getting more drug out of the community, more naloxone and other antagonists out of the community. But if you can really target who are these high-risk folks, so people who have overdosed before, any type of history of substance abuse or substance use disorders, including prescription drugs, illicit drugs, or alcohol, comorbid medical and psychiatric diagnoses, even including things like sleep apnea, being unemployed, being opioid naive. So this would include something like recent release from prison or an abstinence-based treatment program, middle age, polysubstance use, so looking at other medications that may be prescribed or not prescribed, benzodiazepines, antidepressants, and so forth. And then even for prescription drugs, right, prescription-related variables, high dose, specific formulations, and that sort of thing. So, so with that, I'll turn it over to Dr. Knudsen, who can talk about how we address some of these high-risk populations. Thanks.
Thanks so much, Dr. Euler. Good afternoon, everyone. So as part of the Healing Community Study, in both waves of the study, we have built what we call our overdose education and naloxone distribution hub with many spokes. So our coalition partners were really important in helping to set priorities of the types of venues in which we sought out to promote the adoption and implementation of OEND. But the hub is located at the Center on Drug and Alcohol Research at the University of Kentucky in Lexington. And that houses a lot of activity. And then we build partnerships across a whole range of different types of organizations. So we sought out partnerships with criminal legal system entities, with healthcare entities, and a wide spectrum of organizations involved in behavioral health and recovery, as you can see here. And all of these have shown that scaling up overdose education and naloxone distribution is quite feasible in a whole range of settings. Next slide, please. So our naloxone program, when we built it, relied on our HCS physician, and you'll hear from her later, Dr. Michelle Lothwell, and we dispense no-cost naloxone to partner agencies using what's called a standing order agreement. Those partner agencies then are responsible for distributing naloxone to community members. The important piece is that the partner agencies have agreed that they will train individuals in overdose prevention and response before distributing each unit of naloxone. We built this system, though, to protect the individual identities of people. So we don't need the patient's name. We don't need to put that on the prescription label that we were using as part of the study. We just label it for the organization. And then we developed some data management tools so that our partner agencies could send information back to us, just documenting each unit of naloxone that's been distributed through a very short anonymous survey that helped us to understand the characteristics of people receiving naloxone, as well as helping manage the inventory of naloxone. So making sure we had enough naloxone ordered from the distributor and making sure all our partners had enough naloxone. Next slide, please. As Dr. Euler mentioned, we developed overdose education materials. One option is a short 9-minute video. It's posted on YouTube, but we'd be happy to send out the links to any local communities that are interested. And we actually had those that video translated into multiple languages. And so we can also share out those links if those are of interest. In addition, we also developed a paper-based educational trifold brochure. It contains similar information to the video, but we ensure that this brochure accompanies each unit of naloxone. And again, this is available in multiple languages as well, and we're happy to share this with local communities as well. Next slide, please. So in terms of how we staff our hub and spoke model, we have two really important teams involved. The first is the naloxone dispensing team, and the second is our team of implementation facilitators. Next slide, please. So the naloxone dispensing team is located in Lexington at our hub, and they have three main responsibilities. They order the naloxone from the distributor. We're using the Narcan product, so they place orders with Emergent Biosolutions. They then label and dispense and ship the naloxone to each of our partner organizations, and they monitor data coming back on naloxone distribution so that we can keep our inventory reconciled throughout the course of the study. Next slide, please. And then our implementation facilitators do a lot of work in terms of building out the multiple spokes. So implementation facilitators work to recruit partner organizations to become part of our work. And then they use a variety of implementation strategies to support those partner organizations over time. Next slide, please. So these strategies begin with helping agencies to explore the possibility of integrating overdose education and naloxone distribution into their agency. So there's a brief educational meeting. And then implementation facilitators work with each agency to prepare them for implementation. So some of the preparation steps include obtaining that signed standing order agreement, that formal commitment to build the partnership. They work to identify and prepare a champion for OEND within each agency, a person in each local agency that's going to oversee the process and be responsible for the partnership. And then we do provide an iPad to each agency. That's partly so that they can submit data to us, but also have that iPad for showing the overdose education video. And we share, of course, the paper forms as well. And the implementation facilitators train agency staff in the process and help them to implement this strategy in their agency. And then over time, the facilitators continue to work in an ongoing way with partner agencies. So they meet periodically to talk about how implementation is going. They provide data back to the agency about how much naloxone has been distributed and help agencies think about ways they may want to modify their workflows in order to be able to reach more people. They also, as new staff join agencies, provide additional training for new staff. And then the study is providing the funding for the naloxone itself and for shipping it and the educational brochures. And then as the study winds down in each of the two waves, the implementation facilitators work with agencies to see if they want to transition to the state's core KPHA naloxone program. Next slide, please. And so we've looked at a variety of outcomes in our Wave 1 counties. We were real interested in understanding how interested organizations even were in exploring the possibility. So were they willing to meet with us? Did they adopt OEND, meaning did they get at least one shipment of HCS naloxone? And then, of course, importantly, how many units of naloxone were distributed? And that's our measure of reach. And lastly, were they interested in transitioning to core and KPHA to sustain overdose education and naloxone distribution over time? Next slide, please. So we got started in May 2020, just as COVID was really starting to impact our state, and continued our work through June of 2022. And we attempted to recruit 209 organizations in 8 counties. And these are the implementation facilitators that work to recruit them. And 85% of those organizations agreed to meet. And ultimately, we had 69% of those 209 organizations receive at least one shipment of HCS naloxone. And over the course of the Wave 1 period, those partner agencies distributed almost 41,000 units of naloxone. And we were really heartened to find that most all of the agencies that implemented OEND wanted to continue it. 88% agreed to get connected to the state core KPHA naloxone program. Next slide, please. So how might this look for a county that wants to implement something similar? What do you need to get that off the ground? The first, of course, is a location to receive shipments of naloxone from the distributor and to store it. We think that in terms of staffing, perhaps one full-time employee could combine the roles of the naloxone dispensing team with the implementation facilitator. So that person would be responsible for shipping naloxone to partners, to engaging potential partners and providing them with technical assistance, and maybe even doing some pop-up events in local communities, like in public spaces or public events, to get more naloxone into the community. We would encourage folks to use some kind of free survey platform like SurveyMonkey to ask partner agencies to record those naloxone distributions, because we found that's really helpful for inventory purposes. And next slide, please. We also want to make sure everybody is well aware that naloxone is now available over the counter. So some things about our model that can be changed by local communities. You don't need a physician anymore to sign a standing order agreement now that we have over-the-counter naloxone. The labeling, a prescription labeling, is no longer required, but we would encourage QR codes so that you can link to a distribution survey for the purpose of inventory control. We still think overdose education is really important. In terms of cost, it's about $45 per unit of naloxone. And you've got the information here about how it can be ordered for your local communities. And with that, I'll turn it over to the Menu 2 team.
Thank you, Doug and Hannah. We now have Dr. Michelle Lothwell, who will provide an overview of Menu 2 strategies. Dr. Lothwell is the medical director of the First Bridge Clinic and also the co-investigator on the HEAL study.
Good afternoon, everyone. I'm going to talk about medications for opiate use disorder treatment. And this is a really big focus of our evidence-based practices in this particular menu, because particularly methadone and buprenorphine decrease mortality quite a bit. So this is a slide showing you the mortality rate of the general population. If we make that the reference group and assign it a mortality rate of 1, we compare those persons with opiate use disorder that do not receive medication treatment that's FDA approved, particularly methadone and buprenorphine, their risk for death is 6-fold higher than the general population. Now, if we take those folks and we look at people with opiate use disorder that do receive methadone or buprenorphine treatment, their mortality is going to be reduced by more than 50%. It's still a little higher than the general population, but it is greatly reduced because the illness is being really being addressed and treated quite well. So it's very difficult in medicine to find mortality reduction with medication treatment like this. This is why this was a primary focus in this study. Next slide. So importantly, it's not just reducing mortality, it's reducing morbidity. So other things that it's doing is it's decreasing illicit opioid use. It's reducing crime, particularly property crime, decreasing the risk of spread of infectious diseases like HIV, hepatitis C, and other skin and soft tissue infections, bacteremia, other infections like that you might have heard about, like infection of the heart valves called endocarditis. You see an improvement in social functioning as well, and retention and treatment. However, there's been a gross underutilization of these medications. So this pie chart, if you take the pie chart and the whole pie chart is people that have opiate use disorder, just under 15% receive an FDA approved MOUD. That's why this was such an area that was felt that we could really have a big impact on reducing death and morbidity. Most of the folks that do get on medicine, what they're just showing you, most of it is also methadone and buprenorphine, less is naltrexone. So within Menu 2, it was such a big menu. We broke it down into 3 different parts. One is just overall trying to expand and make the medications more widely available. And then to kind of hone in more, we're looking at linking people to treatment. So thinking about where are people that are high risk for overdose, that are using illicit opioids, likely to have an opiate use disorder. How do we help them? Where are they at? What kind of venues? What kind of programs? And how can we then link them to treatment? And so some examples of places that we were particularly successful, I think, in linking people to treatment were syringe support programs, and other venues where we know there's lots of people with untreated opiate use disorder include our criminal legal settings and hospital settings. But we know that we need to let people stay on medication as long as what's needed. So it's important to retain people on medication. And so what we did was most of the time was we selected where you were trying to link people to care, that you also try to, the places where you're linking, that you also try and help them retain. And one of the mechanisms that we did that with was using retention care navigators and peer recovery coaches, and then really assisting with common barriers like transportation. Next slide. So in terms of expanding access, things that can be helpful here is offering technical assistance and facilitating implementation of medication treatment expansion at community agencies. Some examples, we've been working to help increase availability mobile units that provide buprenorphine treatment. You can also reimburse costs of methadone or buprenorphine at opioid treatment programs where patients might be insured while at the same time you're helping them apply or obtain for Medicaid. So, when someone's looking to start treatment, sometimes this is a golden opportunity. We don't want to push them away. Next. In terms of linkage and retention support, we developed two workforces and trained them with a robust training program to make sure that both workforces really had excellent health literacy around substance use disorder, common barriers and comorbidities, and good knowledge around the FDA approved medications with just like you would think of like someone who has diabetes, wanting to make sure that people understood diabetes is an illness and the medicines that are used to help that, along with other important aspects of care. So we had nurse and social work care navigators. These folks conducted in-depth assessments, helped navigate the healthcare system, and addressed multiple medical and psychosocial needs and solved barriers. And then we had peer recovery coaches, which are people who have lived experience of substance use disorder, who are in remission and recovery themselves, help others to link to care, retaining care, building recovery capital, and also addressing barriers to MOUD and making sure that they have good health literacy. So we have some examples that we're going to go into more detail. So if you feel like there's a little bit more concreteness that you can hold on to. You're going to hear some talks next from Voices of Hope, which is our recovery community organization that really we partnered with and had great success with peer support specialists. And then also Bluegrass Healing Transitions. That's a Bluegrass Care Navigators. Great success there. That's who we worked with for our nurse and social work care navigators. You're going to hear about just how important transportation is, and also, working closely with the criminal legal system. And I will pass it back to Lisa.
Thank you, Michelle. We will now hear from Shelley Ellswick, who is the CEO and president of Voices of Hope.
Good afternoon. I am also the co-founder, and I could tell you about my former life, how I was a CPA or how well I did in school. But what I hope anyone remembers is my story, which is that I am a mother who has experienced the pain and chaos of a beautiful child with addiction. I could tell you about his homelessness, his involvement with the criminal legal system, or his perceived betrayal of those who loved him most. But that is not his story. His story is that he used his experience and education to become an assistant professor at UK to research and educate about addiction and recovery. I could tell you the research that shows that peers, those who have lived experience like my son, help individuals build recovery capital, which is everything intrinsic and extrinsic that supports recovery. I could tell you that peers reduce substance use and improve treatment adherence. They reduce hospitalizations and improve relationships with healthcare providers. But that isn't the story I hope you remember. I could tell you statistics. We have 82 partner agencies in 21 counties, and we have 90 highly trained and supervised staff who are in recovery. But that still isn't the story I hope you remember. I want to tell you the story of Mary Ann. She's a composite recovery coach for Voices of Hope. She grew up in a home where drugs and alcohol were present throughout her childhood. Her mother was addicted to heroin, and I guess therefore it didn't seem like a big deal to smoke marijuana with her regularly. She became addicted at a young age, had a baby 11 years ago that she had to give up for adoption, and was engaged in the criminal legal system. She's been in recovery for 4 years, and she's now able to have a relationship with her 11-year-old son and has 2 children she's able to raise with her partner. When Mary Ann talks to people at syringe access programs, opioid treatment providers, or people in the criminal legal system, they can hear her because she shares their story. She has no judgment for them, only compassion and connection. The participants she works with trust her with their stories. A particular participant, Bob G., had been having a really difficult time figuring out what recovery meant to him. He was new to recovery and hadn't really been consistent with his medication appointments. He didn't even believe that medication was really going to help him. He enrolled with Marianne and began to open up more and more in coaching sessions. He worked on goals and motivations with Marianne's support and was working toward how he could participate more in his recovery. Today, he's more consistent with his appointments, and he has hope because he has a role model in Marianne, someone who was where he is and is now where he hopes to be soon. He just told Marianne the other day how appreciative he is to have a relationship with her after feeling like no one had his back for so long. He's feeling heard and encouraged. There is research behind the use of peers and statistics that I could share about the great work that our staff has done in communities across the state. But what I hope you remember is the story of Marianne and how she makes a difference. Thank you.
Thank you, Shelley, for the powerful stories. We will now hear from Jamie Cody, who's the manager of Bluegrass Care Navigators Transition Care Program.
Good afternoon, everyone. As mentioned, our care navigation program here at Bluegrass Care Navigators was developed in partnership with UK's Healing Community Study. What's unique about our care navigation program here is that it is specific to opioid recovery. So while we're helping individuals navigate healthcare resources and services, we're really focused on getting individuals linked to that evidence-based, FDA-approved medication treatment that we know saves lives. So for those already connected to medication treatment, but who are at risk of falling out of treatment, we're working to help them stay retained in treatment. And in doing so, of course, identifying barriers to care and solutions to overcome those barriers. Ultimately, we want to see overdose deaths reduce and see individuals in a remission and stay in recovery. Currently, we're working in partnership with over 25 community-based agencies and healthcare organizations in Central, Northern, and Eastern Kentucky to provide these services directly to individuals in need. Next slide. We provide two models of care, so our linkage and retention programs, and these are staffed by care navigators who are nurses and social workers who have experience working with individuals with opioid use disorder. We're working directly with them, both on-site at agencies that we're partnered with, as well as in-home and telephonically, and really meeting clients where they're at. So sometimes that may mean meeting them at a homeless shelter or another community setting. And we know that care doesn't stop when business hours end. So we do provide our clients with a 24/7 office number where they can connect with a nurse or social worker to address any concerns that may arise after hours. Next slide. So our initial assessment begins at that first contact and is ongoing throughout the time we're working with someone, really helping identify and overcome any barriers to treatment and recovery. So these could be unstable housing, unmet medical or mental health care needs. Maybe they don't have transportation to their appointments, and really work to connect individuals to resources to address these barriers. And where resources may not exist, we're utilizing specific barrier relief funding to meet those immediate needs while we work on a more long-term sustainable plan. So again, maybe to help meet an emergency housing need, provide urgent transportation to treatment or medical appointments. Next slide. So initially for our highest risk clients, which are generally those who are not yet linked to medication treatment, we have daily touch points with them until they are established in treatment. And for those that are already in treatment, meeting with them at least weekly for that first 90 days that we're working with them, and then adjusting our contact based on their individualized needs. And that frequency can increase or decrease, again, based on what those specific needs are. And of course, continuing to reduce the risk of overdose deaths by providing education and ensuring our clients have access to naloxone or Narcan. Next slide. Lastly, what does a successful partnership look like? Of course, good communication between our agency partners and the care navigation team is important. Having a low barrier referral process that helps us connect quickly to individuals who are in need of support, and meeting them where they're at is also key. and truly a shared vision of wanting to see individuals achieve remission from opioid use disorder and see reductions in overdose deaths. So getting to share in those successes with our partner agencies and our clients and their support systems as we see people in a recovery and ultimately go on to live self-directed lives. Next slide. And with that, I will pass it back to you, Lisa.
Thank you, Jamie. And we will now hear from Carly Hickey, who is the transportation manager for the HEAL study.
Thank you, Lisa. Go ahead. Yep, perfect. Thank you. So I wanted to just talk about our transportation strategy and why it's so important. So a little bit of background on how the transportation assistance strategy came about. We found that transportation was a primary reason that individuals were unable to remain in treatment for medications for opioid use disorder. I've listed a few other barriers there below, but one of those being this term transportation deserts. And this is something that our team has really found in more of our rural counties here in Kentucky, where there really isn't any public transportation options, and there's no to limited availability for Uber or Lyft or taxi services. So a lot of the reason we had to get creative with trying to figure out transportation options that would be helpful for our partner agencies and the patients that they serve. So we had to look at multiple different options, as I have listed there, through transportation agencies and Uber and Lyft and fuel cards, and then also just lean on this in-house transportation that some of our agencies already had established. So we can go to the next slide. Our team came up with a few options that we felt like served our partner agencies and their patients the best. This first model is our reimbursement model. The way that this works is our partner agencies purchase the transportation assistance, and then monthly they will just submit an invoice along with data to be reimbursed for those funds that they used on transportation assistance. So I have listed some of those examples there. Bus passes, Uber and Lyft probably being the most heavily relied on currently, I would say. And then also we have a few agencies that we have partnered with that already had vehicles that they had at their agency that they would use to transport patients to treatment. And we've been able to come alongside them and really use our transportation assistance funds to support that vehicle through leases, fuel charges, and insurance. So this model was really used to help support already established transportation at agencies, and then also just help our agencies get creative with how we can best serve them and their patients through the transportation assistance funding. Next slide. And then these other two options here, fuel cards and Uber gift cards. So we purchased both of those in bulk here at the Healing Community Study. They're $20 each. The fuel cards can only be used on fuel cards. And then the Uber gift cards are $20 each as well. And we ship those to our agencies via FedEx. And we just let them, our partner agencies, give those fuel cards and those Uber gift cards out as they see a need arise. So the fuel cards we have seen where our patients that are carpooling to their appointments, these fuel cards have been really helpful for them to give a $20 card or $40, to the person that's getting them to their appointments each week. And then the Uber gift cards we've seen where that's been really helpful for our partner agencies who have individuals who don't have a vehicle at all or any other means to carpool. So this has been really helpful for them to just be able to give them a $20 Uber gift card to get to treatment and stay in treatment. Next slide. So I just wanted to give you a brief, small glimpse into the large impact that this transportation assistance strategy has had across our wave 1 and wave 2. Next slide. So in the first 8 counties that we were active in, which I've listed there for reference, the average monthly cost across those agencies, which was about 30 agencies, was $1,400 a month. And then the number of unique individuals that we were able to serve throughout the time that we were active there in those first 8 counties was 8,136 individuals that we were able to help. So this unique number, each individual is only counted once, regardless of how many services they are provided. So that should give you a pretty hopefully a pretty good idea at how important and the transportation assistance was and how many individuals we were able to help just in those first 8 counties. Next slide. And then now in the second 8 counties that we are working in, I wanted to show you just a snapshot of how those agencies are using their transportation assistance budget. So as you can see here, 57% are using fuel cards, 18% are using bus passes. So those are very helpful to our partner agencies and the patients that they serve. Next slide. And then the second 8 counties that we are currently active in, this data is just from January to September, since we are still in this implementation phase for our second 8 counties. I was really only able to take a snapshot from just this past month. So the average monthly expense for September was around $1,200 across our 29 agencies. And then just so far in the second 8 counties that we've been active in, we have been able to help 3,072 unique individuals. So I'm hopeful that this gives you just a little bit of a glimpse into how important the transportation assistance has been and how many individuals we've been able to serve and help stay in treatment with the transportation assistance funding. Thanks, Lisa. I'll turn it back to you.
Thank you, Carly. Now we'll have Dr. Margaret McGladley back with us presenting on the criminal legal strategies.
Go to the next slide, Lisa. So we wanted to include this particular slide based on a question that we received before the presentation about ideas for law enforcement related investments, which are covered by the Kentucky Revised Statute in number 13 and number 14 of those allowable uses in section 5 here. So in the Healing Community Study, working with local law enforcement, we adapted a strategy to meet the needs of local law enforcement agencies, or LEAs, by identifying champion LEAs to host OEND informational sessions for LEAs in the area. And then we provided information sessions focused on LEA concerns such as diversion and liability, and included perspectives from former police chiefs and community members with lived experience in those sessions. And then we educated the agencies on the process for submitting the naloxone request to the Kentucky Pharmacists Association. And we saw out in the chat here, if folks didn't see that earlier, Dr. Euler provided information in response to the question about naloxone for first responders in education context with the FR CARA program. So ODCP is supporting both of those programs. Thank you, Van Ingram. I think you will be on this session as well. And you have the link here to the KPHA website for requesting Narcan for local law enforcement, and more information about the FR CARA program also out in the chat. One last piece on local law enforcement. We didn't implement any of these linkage menu 2 activities with local law enforcement, but I prepared separately for other projects a research brief on co-responder models that integrate law enforcement and behavioral health practitioners in responding to crisis situations. And I'd be more than happy to share that with anybody who is interested in receiving that material. On to the next slide, please. People who are incarcerated with opioid use disorders face particular challenges. During their time in prison or jail, many untreated people will experience a reduced tolerance to opioids because they have stopped using drugs while incarcerated. Upon release, many will return to several levels of use to what they had used before incarceration, not realizing that their bodies can no longer tolerate the same doses and increasing their risk of overdose death. In Kentucky, the risk of death of released folks from prison is 12.7 times higher within 2 weeks of release than for state population residents. So in recognition of some of these issues, the Kentucky General Assembly has established a jail and corrections reform task force that the first meeting was on June 11th, 2023. And I've included the link here. There's a meeting of this task force actually later today as well. And in this initial presentation, there was conversation with the Kentucky Jailers Association about how Kentucky jails combined hold the largest number of mentally ill Kentuckians with very little access to mental health care or substance use disorder providers. And they propose resolutions to expand access to substance abuse treatment programs inside and outside jail facilities. So this is a great opportunity at the state level with Kentucky General Assembly guidance for broader conversations around county jail management with the Corrections and Jail Reform Task Force that we have information about here. Before the presentation, go ahead, if you could go back. Before the presentation, we were asked whether abatement money can be used to fund MOUD treatment for those leaving incarceration. The answer is an emphatic yes, with number 27 of the allowed uses of the statute, specifically focusing on people involved with any stage of the criminal legal system. HCS is pursuing funding now that would allow us to work toward a statewide program educating jailers and connecting people at release to treatment. We were also asked about specific ways that small county jails can use abatement funds, and the rest of my remarks will address this very question. So on to the next slide here. So we want to share from Madison County Jail, one of our Wave 1 partners, the OEND model that they used. During the study period, they distributed more than 1,500 units of naloxone, and overdose education was provided throughout the facility with lots of collaboration from the staff, collaborative goal setting, and evaluation of how well we were reaching everybody who could benefit from overdose education and naloxone distribution. And our recovery coaches working in that space had full access to the facility, including access to IT systems to track OE completion, to make sure that folks who had done the overdose education while in the facility were receiving naloxone at release as well. And so that staff burden was reduced by allowing those recovery support coaches to access personal effects to place that naloxone at release. And another component was the vending machine that Madison County Jail has established, which has distributed, to our knowledge, 265 units to date. Next slide. So we've, in partnership with Boyd, Madison, and Louisville Metro Detention Center, we have been using FEAL funds and resources to provide technical assistance around the use of harm reduction and Narcan vending machines. And this is a screenshot from a fact sheet that you all will receive after this presentation on some of the different kinds of options around vending machines, 3 different vendors that we worked with to get different kinds of quotes, some of the different options in terms of sizes and prices that you'll see in this fact sheet that you'll get after the presentation. Next slide. So on to menu 2 activities. In jails and prisons in Kentucky right now, Vivitrol is offered in all 8 prisons and 22 jails. Kentucky DOC has received additional funding from CORE to offer buprenorphine in 3 prisons as a pilot, and 1 jail, Kenton County Detention Center, is currently offering buprenorphine, but there are limitations in terms of access to medication treatment to pregnant women and/or pre-release Vivitrol and naltrexone in some of these facilities. And generally, concerns about diversion in facilities has limited use of agonists and partial agonists, methadone and buprenorphine, despite ADA requirements. So because opioid use disorder is a chronic medical condition that substantially limits 1 or more major life activities, the Americans for Disabilities Act, ADA, gives civil rights protections to people with disabilities. Discrimination based on the use of MOUD or the withholding or discontinuation of MOUD as a public entity policy are violations of the ADA. So in April 2022, the Department of Justice issued a guidance document to explain how the ADA protects people with OUD who are in treatment or recovery from discrimination in a number of settings, including employment, healthcare, and participation in state or local government services and programs. The guidance document from the DOJ also announced settlements with drug courts and community supervision programs in Massachusetts and Pennsylvania for discrimination against people with OUD and for limiting the use of MOUD. In late 2022, a settlement was reached with the Lexington-Fayette Urban County Government's Department of Community Corrections to ensure that people who take medication treatment for opioid use disorder can remain on their medication while in custody at Fayette County Detention Center. This agreement with the U.S. Department of, the U.S. Attorney's Office ADA Compliance Review, it resolves this compliance matter, which it was determined as a matter of policy that the facility did not provide most individuals with OUD with methadone and buprenorphine. And the settlement agreement requires the FCDC to revise its policies to provide access to all 3 forms of medications to people with OUD and ensure that decisions about treatment are based on an individualized determination by qualified medical personnel. Next slide, please. So to help support our county jails with implementing medication treatment in their facilities here, we've developed a number of different kinds of resources. The one that you see here and you'll be receiving after the presentation is some template language for a request for proposals that our team developed with our treatment team, so that when county jails and their fiscal courts are contracting with private medical providers to offer comprehensive medical services, requirements around MOUD access and treatment consistent with the ADA are part of that contract and proposal. We've also included links to resources on how to budget for medication treatment in detention center facilities and around diversion concerns. And these are from kind of the natural experiment that's been provided by the state of Massachusetts, which required that access to medication, all three forms of medication treatment, be provided in all jails and prisons, including county level jails. In addition to this RFP document and these resources here, we have a workflow document on how to coordinate this kind of care and the complexities of the pharmacy and medical provider workflow. We also have a consent to treat document, and we are in the final stages of implementing Sublocade in Knox County Detention Center for those already on buprenorphine at entry. So I'd love to talk more with any folks with county jails who are interested in using these resources. Back to you, Lisa.
Thank you, Margaret. Next up is Dr. Laura Stinson, who is the academic detailing pharmacist with the HEAL study.
Hi, everyone. I am going to review menu 3 and explain a little bit about what academic detailing is and focus on our medication disposal strategies. So menu 3 is the prescription opioid safety menu, and our goals are safer opioid prescribing and dispensing practices. So we're looking at prescribing for acute and chronic pain across a variety of healthcare settings, and also dispensing. So focusing on people writing the prescriptions and the people dispensing the medication to patients. And then there's an optional strategy for safer opioid disposal practices, and all of the counties so far have opted for this strategy. And this includes prescription drug drop boxes and mail-back programs. Next slide. So for the safer prescribing and dispensing part of menu 3, we use an educational outreach program. So this includes academic detailing. We can visit with a pharmacist or a healthcare provider one-on-one or in small groups and have a brief session to focus on what their issues are related to pain management and opioid prescribing, and help provide them with strategies, information, tools that they can use to help with opioid safety. We offer continuing education for this. We have online continuing education modules. We offer live group CE. Something we do for pharmacies is we call it a mini visit, where we drop by and talk to the pharmacist for maybe 5 minutes and provide some materials. We found that this was the best way to reach busy pharmacy settings, and we also provide outreach to health colleges. So we're reaching the next generation of healthcare providers. And you can see in the picture some examples of the materials that we provide during all of these things. Next slide. So this would be something that could be included with opioid abatement funds, projects that support efforts to prevent overprescribing and ensure appropriate prescribing and dispensing of opioids. So the menu 3 efforts related to that would be included. Next slide, please. Okay, so on to focus on safer opioid disposal practices. So in a large study like HEAL that is focusing on opioid overdose death reduction, why do we think this is important, and why do we think it's important to provide to other communities? Next slide. Well, again, this is something that can be funded through the opioid abatement funds, projects that are related to providing public education about opioids or opioid disposal. We have provided several promotional campaigns related to this, and providing drug take back disposal or destruction programs. Next slide. I'm going to share some evidence behind medication disposal and why we think it's important. There are risks of having opioids in the home. We know that about half of individuals that misuse pain relievers say their source was a friend, a relative, or it's something that they've obtained for free. A very small percentage bought from a friend or relative, and then a few took without asking. But the majority of those individuals are obtaining medications for misuse for free from someone. We know that just availability of leftover opioids in a household can increase the odds of opioid-related overdose death, and that's up to 60%. We had a question that came in before the presentation that's related to this. We know that among high school seniors, about 37% of those that had past year non-medical use of prescription opioids obtain these medications from leftover doses of their own opioid prescription. So having a prescription for opioids from a prescriber for a pain-related need and then not getting rid of the leftover doses can increase the chance that that's going to be misused. Or the question was, what are practices that prevent opioid misuse among adolescents and young adults? And encouraging disposal of leftover opioids is one thing that we can do. Providing education related to maximizing non-opioid and non-pharmacologic strategies are important. This population is vulnerable, and if we can delay the first opioid exposure until later in life, it can help prevent increased risk of opioid overdose and progression to opioid use disorder. Next slide. We also know from research that many of the opioids that are prescribed for acute pain needs, so this would be injury, surgery, are not used. As many as 50% of the opioid doses that are prescribed for acute pain are not used. And we know that those individuals are not always disposing of their opioids safely. About a third of patients actually dispose of their unused opioids, and about 70% say that they're keeping their opioids for future use. Next slide. We also know from research that pharmacies are a good option for medication disposal. Surveys have been conducted laying out lots of different options for ways to dispose of medication and places. And the study showed that patients prefer to use pharmacies for medication disposal. We know that if disposal collection receptacles are in convenient locations, places where individuals are going to be going anyway, they're more likely to be used, and that patients are more likely to dispose of medication if the recommendation comes from a healthcare provider. So if it's in a pharmacy, a pharmacist is going to be there and can make that recommendation. Next slide. So Kentucky has a unique issue with medication disposal locations and pharmacies. In about half of the counties, this was 2020 data, there were no pharmacy-based medication disposal locations. And many of the counties with higher opioid dispensing rates have the lowest number of disposal options. So this map shows the colors represent opioid doses per 1,000 residents, and then the orange circles represent the number of disposal locations, with the larger circle being a larger number of locations. And you can see that many of the counties that are the darker shades representing higher numbers of opioid doses either don't have an orange circle or have the smallest one representing only one disposal location option. So we have lots of room to grow here. This data was before the Healing Community Study started. So some of those counties that don't have an orange dot now have at least a small one, but there are still many areas in the state that don't have enough disposal options. Next slide. Go back one slide. I'm sorry, I forgot to say something. And this doesn't mean that increasing disposal locations is going to decrease opioid prescribing necessarily, but just shows that areas where there are higher rates of opioids being dispensed, there's a greater likelihood that these opioids are going to be left over, and we need options for medication disposal. Next slide. So the program that we offer through the Healing Community Study, we look at each county, look at the number of disposal locations that are already available, think about the geographic location, the population that location serves, and then try to identify good candidates. We've worked mostly with independent pharmacies. We have worked with some chain pharmacies, but that is a little more challenging. We then contact the candidates either in person, by email or phone, and explain what we're offering. And this is a medication disposal drop box. MedSafe is the company that we have worked with. They provided this service to the University of Kentucky prior to the Healing Community Study. So we offer to pay for the drop box and 9 inner liners. And after the study is over, the pharmacy will own the kiosk and they will be responsible for the maintenance cost, which is the liners that go inside the blue box. Next slide. So far, we have 57 drop boxes. There's one that has been ordered that is yet to be installed, but it should be installed in the next couple of weeks. So across our 16 counties. And when we started out, there were 5 counties of the 16 that didn't have any pharmacy-based disposal options. And now each of those counties has at least one. Some have very many options now, but we have at least one in each of our study counties. And we've collected over 6,000 pounds of medication, which has been incinerated. And if you want to think about this in terms of how many prescription bottles, it would be about 180,000 of just the regular size prescription vials that have been destroyed. Next slide. So at the end of wave 1, we conducted interviews with all of our participating pharmacies to see if they could provide information, if they could help us improve our program for wave 2. And we found that most of the pharmacies were highly satisfied. They reported high levels of patient satisfaction as well, that this program was pretty low burden. It was easy for the pharmacies. Once the medication disposal drop box was installed, there wasn't a lot of maintenance involved. It's highly visible. So the company that we went with, their drop boxes are bright blue. It's easy for people to see, and that helps with uptake. So if the pharmacy isn't doing a lot of promotion on their own, we did promotion through the study, but if people are coming in, they see this, they notice it, they ask about it, and they find out what it's for. And it's a good way to start conversations about prescription opioid safety. So if someone asks, what is this new thing in the pharmacy? You can start a conversation about the opioid crisis and things that they can do to help keep their community safe. We found that it is cost effective compared to some of the other options. We also offered medication disposal envelopes in locations that maybe didn't have room for a drop box or for some reason could not install one, but still wanted something to offer to their patients. And looking at the cost of both over the long term, the drop boxes were more cost effective when you think about how many pounds of medication were destroyed from each option. We do know something from the pharmacies is that cost is becoming more of a burden. So with changing reimbursement rates and other factors, it's harder for pharmacies to take on anything outside of their normal business. So we do feel like in wave 2 compared to wave 1 that we haven't had as many pharmacies agree to a partnership because of cost concerns in the future. Next slide. So if a county wanted to replicate this program, we have a lot of the groundwork laid. We have training videos, very specific instructions for the pharmacies for participation. And the cost involved would be for the drop box and the liners. So to establish new pharmacy locations in a county, that would require purchasing a drop box, which if the drop box was purchased on its own would be about $1,800. That is for the larger size. There are size options. The 38-gallon is what we recommend just because it holds more. It doesn't have to be changed as often. And comparing the two different sizes, the cost seems to be about the same or maybe even a little higher with the smaller option in the long run. So we provided a launch pack, which was the drop box plus 9 inner liners, and that was a little over $3,000. I did provide some information about the pricing for the inner liners. This I obtained this summer and was pleased to see that it hadn't gone up since last summer. I know the prices on the mailback envelopes had changed, but the liner prices are the same. They do seem pretty expensive, but this does include the cost of shipping and incineration. So when you purchase the liner, there isn't going to be any kind of additional charge unless you go over a certain weight, which very rarely happens. So if you think about sustaining current locations, like these numbers are just for this company. I'm assuming that other medication destruction companies would have similar costs, but the only thing that would need to be provided would be the inner liners. And then promotion, if that's something that you wanted to provide in the community. And from what we have seen so far from wave 1 and wave 2, we think that 2 liners per year for a 38-gallon receptacle is going to be the average per pharmacy. It varies. We have one pharmacy that is using about 1 liner a month, and then we have some that have yet to return a full liner. Next slide. I have a couple of examples just so you can see one for a rural county and an urban county. So this is Fayette County. We already had several options in Fayette County, but we were able to add 7 more pharmacies. And with our estimates, we think that it would be about $3,200 to sustain just the pharmacies that we installed drop boxes in for Fayette County. Next slide. And then Madison County, roughly the same number, but about 2,600. So in rural counties, the use may be a little less. So the overall cost might be a little less. And I have some references if anyone wants to refer to them for the supporting evidence. And I think that is my last slide. And I think it may be our last slide for the presentation.
Yes, thank you, Laura. And thank you to all our presenters today. It was a wonderful presentation, a really great session. We have about a little more than 5 minutes to open it up for your questions. And I'm not sure if any of our presenters here have seen some of the questions come in through the chat box that they would like to address. I wasn't able to monitor the chat box. So if you see something there that we need to address and questions that have been put in the chat box, I'll make sure that we follow up and get your answers sometime in a follow-up email if we don't answer it in today's session.
I see a question that wasn't answered from that Dave just put in the chat around heel tracking naloxone kiosk implementation statewide. That was a little bit of an interesting implementation, Dave, in that our wave 1 counties, Boyd and Madison County, that adopted the naloxone vending machines, they were actually funded by a Bureau of Justice grant to the National Center for State Courts. So they were using Narcan from that the KPHA website there. So we don't have that access to that data. KPHA does have access to that data. We've just gotten up and running with the Louisville Metro vending machine, if that answers your question, Dave.
Thank you, Margaret. Anything else that come through the chat that we need to address here?
Lisa, I think Eric
Yes.
Hagan had a question earlier.
Okay.
And I just want to see if we've answered it. So he asked what work is being done with prevention that is making a significant impact. And I'd like to open that up to the panel to answer that question.
So I could talk about it a little bit. I mean, so from the prevention side, I think we have a few things. So one of the elements of prevention being essentially getting naloxone and things out of the community. So there's that. That's a lot of stuff that we've done within HEAL that we talked through. I think another element of prevention is stuff in safe prescribing and disposal, which are some of the things that that Dr. Stinson talked through just at the end there. So I think those are some of the things. I mean, tying that back and looking at the immediate effects. I mean, we can look at how prescribing and things have changed over time, trying to tie those to exactly when we have a meeting with someone, and then how does their prescribing pattern change? It's a little bit tricky. overall naloxone implementation in communities. We talked about some of the data there, and we're kind of looking at that on a statewide level some too. There's other elements and things that we didn't really get into here as much. So that could be things like from syringe service programs and fentanyl test strips and that sort of thing that we didn't talk too much about here. But I think from our side, those are probably two of the bigger things that I think we've touched on at least some.
Thank you, Doug.
I think one more thing that we really didn't touch on very much today was the group of prevention specialists that we deployed in each of our communities. So we hired individuals whose job it was to actually go to community events and distribute naloxone. They would go to libraries. They would set up what we call pop-up events where they would check with the business owner and see if they could sit out front and just distribute naloxone. And through that alone, in our Wave 2 communities, we've already distributed 17,500 units of naloxone in those 8 counties. And so it was a strategy of just getting naloxone out there, getting that bystander strategy to be accepted. And I think the other thing that did, that also helped reduce stigma around carrying naloxone or people having naloxone, or people having an overdose. It gave them the education they needed and prepared them to respond if ever needed to do so.
Thank you, Jennifer. Any other questions? Feel free to use the raise hand feature too. Was asked earlier about the links going through the chat box, and I will include those all in a follow-up email as well as the PowerPoint slides. So you will have that, and we will have a recording of this video session. So we can share that in a future time. So you'll have that as references too. And if anything else, just feel free to call me or email me, and I'd be happy to send you any of that information. All right, I think I'll go ahead with the CE credits if there isn't any other information, and get everybody out of the room on time. So let me go back to my screen here. All right. Whoops, let me back up one here. So for those of you that are interested in just getting a certificate of attendance, or you are a licensed alcohol and drug counselor, you visit this link here, and it's being put in the chat box by Rose, and just fill out the information, and within the week you will get a certificate of attendance and proof that you were at the session. For our physicians, nurses, social workers, and pharmacists, you will have to visit the CE Central website. It's being put in the chat, and complete that information, enter this activity code that's also in the chat, and you will get your certificate. Now, if this is the first time that you're using CE Central and you don't have an account with them, you do have to fill out some information. It's free, it's very quick, it's very easy to do, but you have to do that step first before claiming your CE credits. And then the last thing I'd like to share is a feedback link. We want to know your thoughts about this session, what you enjoyed about the session. Any feedback that you can provide us is always helpful. It takes about a minute to fill out, so if you wouldn't mind completing this short survey, it really does help us as we design and create these learning collaborative sessions. And then I'll just end with financial disclosure summary that I have to post, just policies about the financial disclosure. But I want to thank each and everyone being in the session today. We really appreciate you coming to the session, and I hope everyone has a great day, and feel free to reach out to me, and I'd be happy to answer any questions that you have, maybe follow up, and you'll see an email from me the next day.
Lisa, there's a question about DLG credit and how to claim that in the chat.
Okay. Thank you, Jennifer. For those that are getting the DLG credit, I am sending Wendy Thompson the attendance sheet. So she'll have proof that that you were here in this session, and then she's going to process those claims.